Good morning, welcome. Thank you very much for joining us as we continue our inquiry into commercial genomics. Perhaps for the record you could state who you are and which organisation you are representing, starting with you, Matthew.
So I'm Matthew Hurls, I'm Head of Human Genetics at the Wellcome Sanger Institute. I also co-founded a company, but I'm not speaking on their behalf, but I noticed they're one of the people who have submitted documents to you. So,
thank you.
I'm Annika Lucassen. I'm chair of the British Society for Genetic Medicine. I'm also a clinical academic in Southampton.
Thank you very much.
I'm Anna Middleton, and I'm the departing chair of the Association of Genetic Nurses and Counsellors, and I also work at the Wellcome Genome Campus in Cambridge.
Thank you very much. I need to ask just before we kick off, do you have any declarations of interest? You've already mentioned the company.
None other than that.
No, thank you very much indeed. Obviously, genomics can tell us an awful lot, and it is a very useful technology, and there has been an increase in the amount of commercial activity undertaken. What information can genomic tests provide, and what can't they provide?
So I would break it down into kind of three kind of areas. I think there's areas where genomic data is useful now. I think there's areas where genomic data is potentially useful in the future, and there's areas where it seems unlikely to be of major use. I think where it's useful now is in things like ancestry, determining people's populations of ancestry, and that's in a non-medical space. Most of the other applications are in the medical space. In the medical space, there's diagnosis of especially disorders caused by single mutations in single genes, and that could be diagnosed prenatally. It can be diagnosed obviously after birth. There is also screening for those same kinds of disorders. That can occur prenatally. It can even occur preconception if couples want to understand if they're likely to both carry a variant which, if both of them pass that variant onto their offspring, would cause a disease. So that's often known as preconception screening. Then there's prenatal screening that can be done either as part of IVF or during the course of a pregnancy. So NIPT, for example, is one example of that, which you've heard about in some of your documents. Then there's also the potential for screening after birth for picking up risk of later onset conditions that are also caused by mutations in single genes. Sometimes these are called incidental findings because one finds them when one's looking for some other kind of information from a genetic test. Sometimes they're called secondary findings. I think you'll see both in the literature that have been submitted to you. So that's the kind of screening and diagnostic side of things. Then there is essentially people responding differently to different kinds of medical interventions. So one person might be given a drug that's ineffective, another person might be given a drug at the same dose, and actually it'll have a very severe negative event. In fact, that happened to my father. He had to be resuscitated after being given morphine. So these things are relatively common in the population. That's often known as pharmacogenomics, and a lot of the evidence is there and is very robust. And then there's kind of related to that stratified medicine is the idea that people's genetics may influence their response to a particular medical intervention. It could be drugs, could be other things. And so one of the big areas where it's used is in cancer, and the idea that people who have cancer that have particular mutations may respond very well to particular drugs. So that's kind of known as stratified medicine. So I'd say that was the set of things where it's very obviously useful now. I think things that are coming in the future are the ability to predict risk of commoner diseases like type 2 diabetes, a phrase known as polygenic risk scores, because it's not caused by any single mutation but by a combination of variants that all subtly influence risk. There's a lot of interest in that currently because of for a number of reasons. One is the science is advancing rapidly. The second is healthcare systems are very interested in preventative medicine, and this potentially fits that bill.
Sorry to interrupt you, but we've heard previously that the genetic part of potential disease actually is quite a small part of it. It might allow, it might indicate that you had the potential to get a disease. It won't say yes you will or no you won't, because lifestyle has a much greater influence on that outcome than the genetics. Is that a fair comment? Or?
I think that's a fair comment, and I think that's a really important comment to remember, because I agree with all of Matt's outline, but I think what is often forgotten is that a genetic test result needs to be heard in context, and on its own it does very little, particularly in a healthy population. So it might predict something quite well if you've got a really strong family history of, say, breast and ovarian cancer. Then a particular genetic finding might explain most of that family history. But if you find genetic variation in a healthy person, then you need much more context around that. And I think that's clear to lots of people, but it's also not clear to others. So there's a sense, I think, sometimes that people conflate the ease of the technology with the ease of predicting what comes out of that information, and that's not at all the case, because more often than not, particularly when people take a commercial test, the information is much less clear-cut than they expect. And some examples recently have been of people who have had a commercial test, who have then, for example, for Ancestry, which, as Matt says, is commonly used, and I've heard a figure of 26 million of these tests being sold worldwide already. But what people then do is send off the data from their Ancestry test to other companies for secondary analysis. And that's where often, although these companies do on their website say, do not use this for health interpretation, people may not notice that or feel, because what they've heard about genetics is so clear-cut that that doesn't actually apply to them. So they go off and they have their test reanalyzed, and they come back with information that, strangely enough, the higher the risk, the more likely it is to be wrong. And that's to do with the technology of the test. But for example, the Angelina Jolie gene, as it's been called, the BRCA1 gene, some recent data from colleagues in Exeter showed that most of the commercial tests that analyse these variants in that gene are likely to be false positives if you get a result back saying that you've got one of these gene variations. And of course, even if that only happens in one woman, that's a big issue, because getting risk-reducing surgery of your breasts and ovaries is a major operation, let alone if it's not warranted because you've got a false positive result.
Absolutely.
Well, I was going to say that only sort of 5 to 10% of disease is really strongly genetic, and not all genes are the same. And so, the best way of working out whether a gene is going to cause disease is to look at a family history. So if you can see generations of disease in a family, then it's very likely to be strongly inherited. And there are some conditions where you need many genes together to get the condition, and there are other diseases where you only need one gene fault and it equals the condition. So it's very kind of complex, and a lot of the commercial testing is not really looking at single high-risk disease-causing genes. It's looking at a whole spread of many genes.
Okay. So just to be clear, when, let's say, an ancestry test is done, the test that's done there would be different to if you were looking for a specific genetic disease.
If you were looking in the health service for a specific genetic disease, you'd tend to target on that particular gene that you are suspecting, and you'd analyse that in detail. Whereas the Ancestry tests look at several 100,000 variations throughout the entire genetic code, and they look at how they've changed in populations over the last thousand years anyway, and how your ancestors have migrated across the globe. And I'd say they're interest tests and shouldn't be used for health interpretation.
That's because you're getting different detail from an ancestor test than you would for one looking for variations that would predispose you towards a disease.
You might appear to get the same information. So those ancestry tests also look in genes like BRCA1 and BRCA2 and other high-risk genes, and they, depending on the technology used, but that's where they might find the false positives. So they might then, if they're reporting on health risks, report variations in that gene that actually aren't there.
So I would say the two kind of applications I mentioned, these kind of single gene disorders, to diagnose those, you need a different kind of test from what's done with Ancestry. Yeah. To do the kind of work that I mentioned that's potentially coming these polygenic risk scores, it's exactly the same kinds of information as the Ancestry test.
Yes, but people often assume they're the same. So people think a genetic readout is a genetic readout, and they hear a lot about how accurate it is, and actually they don't necessarily understand, and why should they, that the readouts are very different, and that certain readouts should only be used for very common variation and not for very rare variation.
And if a member of the public is genuinely concerned about an inherited condition in their family, the best way to get an answer to that is to go through the NHS and have a test from an accredited laboratory.
Thank you. I was just wanted to come on to that. Okay, Bill, go on.
On that one, you're suggesting, and I tend to agree, to go through the NHS, but is there restrictions in certain criteria to be met before you will receive that through the NHS?
Yes.
Should that be broadened, or could that maybe exclude some people at risk? Is the criteria right for that?
Go for it.
So the first port of call is your GP. So if you have a strong family history, say, of breast and ovarian cancer, your GP would then make a referral into a clinical genetics service to have that discussed in more detail. If you're a healthy person who's just generally worried about being a carrier for cystic fibrosis with no family history of that and no particular concerned about something specific, then no, the GP wouldn't make a referral into clinical genetics.
The GP would do a risk assessment on that individual, and if it fell out with the criteria, where does that person go then?
Then they can get recommendations about screening rather than about genetic testing quite often, dependent on their family history. But you're quite right to ask the question, is family history alone enough as a screening test? And sometimes it won't be, because sometimes people don't know about their family history, or they're adopted, for example, or have lost touch with. And I think they're the examples that I'm particularly worried about. So they're the examples that we have seen coming to genetic services around the country, where people have got not a terribly strong family history, but they've had an ancestry test. They've thought, well, let's analyse it for these health variants as well, and they've come up with what they think is something that predisposes them highly to breast and ovarian cancer. And they've then entered their health service with their result to say, okay, well, I didn't have the family history that met the criteria, but I have got this result, and I would like risk-reducing surgery. And they're the ones that are actually more than 90% likely to be wrong. And that creates an awful lot of confusion and extra work. So it's that space that I'd really like to see some more attention being given to. And I suspect the companies themselves would be very happy to engage in that, but we haven't found a way to do that yet.
I think.
Thank you.
Sorry.
Go on. No.
I think there are some areas where there is the potential for people wanting to access diagnostic or screening tests where the NHS isn't providing it for them. So the NHS obviously tries to come to a balance between cost effectiveness. So if one looks at non-invasive prenatal testing, I think, and you can correct me if I'm wrong, that the guidance is that if your risk looks like to be above 1 in 150, then the NHS will offer your test. But if your risk is 1 in 160, you may still feel that's the right thing for your family.
But the problem with the commercial testing is often it is just done direct to consumer without the support and the information around what it actually means and helping actually, public and patients to make sense of it.
Yes. So are there any commercially available tests that have proven clinically useful that the NHS don't offer that perhaps they should?
Not as far as I'm aware.
I can think of one example, but it's largely in the space where, maybe two examples, but one example where it's largely in the space where the science is moving very rapidly. So this is in being able to access tests that confirm that a particular variant is actually the cause of a disease. So I'm thinking of epigenetic testing, for example. This work that my group and others have done, where we know there's a lot of clinician appetite to try and get that confirmatory test, and it isn't currently offered in the UK. So that would be one example. But it is
commercially available?
Yes.
Okay.
Yeah, so that would be one example. I think on the NIPT space, currently there's testing for 3 conditions. There are many, many more severe paediatric genetic conditions. There are, I'm aware, a couple of companies offering tests to screen for more than 3 conditions. I think it's very early days, but I think one can envisage that those tests people will want to expand those tests in the future.
Yeah, and I agree with that, and I think the other area that you mentioned where probably there's more commercial availability that could be harnessed by the NHS is in the preconception space. So finding that both members of a couple are a carrier of a recessive genetic condition is not currently offered by the NHS. The NHS waits for a child to be born with that condition before it offers screening to family members. So that would be another area, I think, where commercial testing could be useful that isn't available in the NHS.
Okay, that's very useful. Thank you very much. Graham Stringer.
A lot of the commercial companies, we're told in the evidence, are not very transparent. Is there anything that can be done to sort of check or regulate the validity and interpretation of their results?
I think they probably are quite transparent, and certain companies actually have excellent websites. So I think the problem lies more in the expectations of the people using the test. So, which is why I might say it's not about regulating the companies so much as improving the information around what a genetic test might tell you and what it might not tell you.
Interpretation of the tests.
Yes, yeah.
And would you have criticism of the way any commercial companies are interpreting the results?
Yes, well, I think that particularly the secondary analysis, I would have criticism that they reveal, when they say they won't reveal health information, they reveal information that is then interpreted as health information. And the context around it is lost completely. And as Anna says, the information provision that you would receive in the NHS isn't there. So why would you then know to take that with caution, that result?
So in the small print, it's often written, don't use these tests for clinical reasons. They're only research. They're based on research findings. But in the marketing of the tests, it's go to your doctor if you're worried about this. This can change your life, change your behaviour because of the results of this. So it's implying that you can use them clinically. But in the small print, it is very clear that they're not to be used clinically.
I would say there's kind of three areas where one could think about regulation. The first is the quality of the data that they generate. I think that's definitely an easily, there are existing quality schemes that exist that look at this. The second is the quality of the interpretation that they give. And I think the third is if companies are seeking to make money out of providing genetic interpretations that have potential psychosocial impacts, then they should be making sure that the provision of counselling around that is appropriate. Now, counselling won't necessarily be appropriate for every kind of genetic test. I'm not sure counselling is necessary for ancestry testing, for example. But in the situations where it is, that's clearly an area where I don't think the companies are doing well. And Hannah can speak much more to that.
Yeah. So, despite recommendations from the European Society of Human Genetics and the Academy of Medical Genetics and Genomics in the US, that all sort of state very clearly that genetic counselling should be provided pre- and post-test when you're testing for really serious life-threatening conditions. Despite those recommendations, most of these commercial companies do not offer any level of support, and they might signpost a customer to a YouTube video saying how great it is to be informed of your genetic risk, but not actually picking up the pieces. And then those patients are turning up in clinic in the NHS very, very anxious and expecting the NHS to pick up the pieces.
And within the NHS, I think there needs to be greater awareness of this. So I know of several examples where just to go back to the example I listed earlier, where people have found a surgeon who's willing to do the operation on the basis of the test result because the surgeon believes the test result, only to find that actually that test that they think is highly accurate was an artefact, and when it's tested in the NHS was found not to be there. So I think we need much better awareness within general practice and within surgery that a genetic test is not always what you think it is, or a result shouldn't be taken at face value.
So how would one move to improving the system on the interpretation and understanding of those results?
We've, I think, some guidelines, professional guidelines. So we are working with the College of General Practitioners on guidelines for GPs on what they do when people come to their surgery with one of these results, and that's likely to be the first protocol for most people who get a result that they're then worried about their health for. So that, I think, will be very important. But to spread that out to secondary care areas as well, so that, for example, surgical teams don't think that when they get a result, that could be taken at face value without further scrutiny.
And also we have lots of guidelines and recommendations on this already, and they've been around for many years, but there's no teeth. You know, the commercial company's not required to actually adhere to them.
So would you recommend a regulator with teeth? Yes.
Yeah.
Yes.
Just a final question. It's not really related to the questions I asked. This is an area of science that's moving very quickly. What do you think the next major steps and improvements in an increase in knowledge in this area will be? How will the area change?
I hope it will be an understanding of the nuance. I think the discourse about genetics has been very much about high-risk genes and strong predictiveness. But as Matt says, we're moving into areas of common risk, where environmental risk factors play much more of a role, where the genetic result will maybe categorise you into a higher or lower risk group. So from a public health perspective, it will be very useful, but not so much from an individual predictive value. So I think getting that message out there and making people realise that a genetic test result isn't, without the context around it, isn't that useful. I think that's a really important development.
And we're moving massively into this digital era, and so Matt Hancock's announcement about the Total Review, which is looking at the future of the NHS in the next 5, 10, 20 years' time with respect to genomics, AI and robotics. And here we're looking at, genomics being integrated into the smartwatch, being integrated in all sorts of risk calculations. And I guess the risk of all of that is losing the nuance and the personal experience of what all that feels like and means. And so there's definitely a need to slow down a little bit on that sort of digital implementation and think about the people behind, the risk.
The context. I mean, the genetic test result on its own means very little most of the time.
Yeah.
Bill, you wanted to come in on this. Thank you.
It's a slightly unusual question, so I'm seeking forgiveness before I start. I'm hearing the possibility of false tests going forward. You secure a surgeon willing to undertake a procedure, and post that it's discovered it was totally unnecessary. Then enter the legal profession. Has there been cases in the past where people have been sued for this, i.e. the originator, I would imagine, would be the commercial company that concluded the test? Has it happened, or is it likely to happen in the future where the legal teams come in?
As far as I know, it's not yet happened, but this is very early days of this being possible, and court cases often lag behind about 10 years after they've happened, so I imagine it would well be possible in the future.
Events of today could appear in court a decade from now.
Yes.
As a result of what may be the wrong testing as opposed to wrong diagnosis. A test is not a diagnosis as such, is it?
Correct.
So that could happen, but no history of that as yet.
As far as I know, I'm not a lawyer though.
No, not I.
Just before I hand on to Martin, excuse me, the equipment the tests are conducted on, does it either work and give you an accurate result or not work, or can it give you results that change over a period of time? Does it need to be re-evaluated, reassessed, and I don't know what the word would be, calibrated, I suppose?
So I was just going to say, because there's two phases of it, there's the generating the data and the interpretation of the data. The interpretation of the data definitely changes over time. And because we now know that a genetic variant in a particular gene really does cause a disease, whereas we didn't when the test was actually done. So that's the bit that changes most rapidly, and actually that's one of the challenges for the healthcare system, is how to take, as we're now doing genetic tests that are much broader in scope, testing all genes in the genome, for example, that one has means of going back and reinterpreting those data. There's huge value in doing that, but it's quite challenging to the system. The machines themselves, typically competent people can generate high quality data out of those machines. They're pretty robust technologies, but it's the combination of the generation of the data and the bioinformatics that calls the variants on those data. But it's a very easily accessible thing. So in terms of regulation, it would be relatively easy to do.
Right.
Yes, but it is important. I mean, you'll have known about this for a long time, but it's quite recent news for me that the rarer a variant, the more likely SNP array technology is to get it wrong. So it's not that the technology is completely robust. It depends on what technology you're using. That it is the bioinformatics of it, isn't it? The bioinformatics calls that wrong when it's a very rare variant. And of course, the rarer the variant, the more predictive it's likely to be. Is that fair?
Okay. Thank you very much.
Can I just
briefly, Vicky?
come in really quickly on the question about the regulator? Is it the issue that the regulator doesn't have teeth, or that there's not enough clarity for the regulator and it's not regulated enough?
Well, no, I was not specifically talking about a regulator. It was more the recommendations that are in place from the professional societies. So there's loads of recommendations about direct-to-consumer commercial testing from all the organisations that represent the clinicians on the ground. But it's those recommendations that are not being...
So there isn't a regulator?
Well, it depends which regulator you're thinking of. If it's the in vitro diagnostics regulation, it could come under that.
There's a lack of clarity in the whole regulatory framework.
Yes.
Lack of clarity together with a lack of understanding. Excuse me.
And I think actually one of the things that struck me from reading the documents that you received was actually many of the companies would like regulation to a bar that they know they need to hit.
Helpful.
Thank you. Martin.
Thank you, Stephen. Excuse me. We've already heard this morning that there's a challenge with the education, there's a challenge with the information, and also there's been a lot of mention about the challenge with the counselling. So I was going to try and take the opportunity to delve into the counselling side of it, but in no way allow the education of those who are involved, and probably more importantly, the information and education of the public about these things to go by the way. And it's interesting that counselling led to the largest group of evidence that's been submitted to us as an area for this. So I suppose, and I know, Professor Middleton, that your association submitted evidence. So maybe if I start with you and say the big question, what counselling should be offered? In the perfect world, what counselling should be offered alongside the testing?
It's important to say that the counselling we're talking about is not therapeutic counselling, it's genetic counselling, which is actually quite different, and the interactions are usually just one-off. So genetic counsellors are highly skilled, postgraduate educated, regulated professionals that register with the Genetic Counselling Registration Board. They're skilled in genomic medicine, clinical genetics, but also care of the family. So their job is to help families navigate their way through the testing. Who's going to be tested, what does it mean, how do they want to incorporate that into their lives. So that's what genetic counselling is. There's a very large space for genetic education, which is very different. So, and anybody could do that. So you just need to understand what genes do. Any health professional could do that, a website could do that, a chatbot could do that. But it's that interaction where you actually explore, what does this mean for you? Do you want to have your children tested? At what point could they be tested, and why? And what screening might they access if they're tested? It's that kind of holistic care that is genetic counselling. And I would say that as a discipline is what should be available when we're talking about really serious life-threatening conditions. And there's an opportunity here for genetic counsellors to really specialise in that, but to support their other clinical colleagues to have conversations about genetics when they're just dealing with a patient in front of them.
I think you mean serious high-risk conditions that are largely determined by genetics, because there's lots of serious high-risk conditions where it wouldn't be very predictive, and then I think...
we're talking about inherited conditions.
Yeah, so what you're doing is you're granting someone who's thinking about a test, undergoing a test, and post-test results access to a specialist that can formulate the nuance of the information that's coming in. Is there, or should there be, different levels, different steps of counselling depending on the generic test? Or should that, and I'm going to use this and regret it immediately, that gold standard of identified counselling be available for all generic testing because of the nuance that you're talking about and the change that's happening?
No, I don't think genetic counselling per se should be the gatekeeper to being able to access a genetic test, but it's context specific. So, for example, if there's a woman with breast cancer who's going to see her oncologist and she has a diagnostic test for one of the breast and ovarian inherited genes, and she's found to have a mutation in one of those genes, that can be really relevant to determining the chemotherapy that she has and the surgery options that she has. And the oncologist could have a very sophisticated conversation about the fact we've done this test, this is what we found. But the oncologist is not going to say to that patient, okay, have you got any sisters? Should we test them now? When should we test them? Who else in the family is at risk? That would be somebody else who would be doing genetic counselling, who'd be doing that picking up of the pieces in time.
Rather than the generic test, it's actually the individual that the counsellor comes across that they can bring their expertise and knowledge to suggest wider review, research, or other questions that could be prompted. So I suppose the question, which flows from a lot of the information that we were given, that's a face-to-face discussion. I mean, I accept it maybe by telephone, but that requires a human interaction with the human that's undergoing it. So what are the panel's views on this idea of trying to get away with just written counselling or AI counselling or flowchart counselling? I mean,
that wouldn't be counselling, that would be information giving.
Yes.
Counselling has to be a two-way process. It's a dialogue and it's patient-centred because it's focused around what the patient needs.
And I think our recommendation would be that counselling is recommended for the very high-risk conditions, but they are rare. So yes. I don't think you would be calling for, and certainly the BSGEM wouldn't be calling for, counselling for all genetic tests. And when we're talking about the direct-to-consumer test, most of them will not be ostensibly for very high-risk conditions. So I don't think we're saying we think that is really mandated. What we are saying is that these consumers can find themselves getting what they think is high-risk information without ever having seen a counsellor. And they might have benefited from seeing a counsellor before they were in a position to get that information.
Yeah.
Again, I'm being terribly negative this morning. I dare say if somebody gets bad news, for want of a better word, having underwent a test, and they fail to engage with a counsellor properly, could it lead these individuals to some form of depression or some event in their life that makes that counselling almost essential, particularly if their mind runs riot with this news they've got, maybe unexpected news or maybe anticipated news, but once they get it, they can't manage it. Yeah. So would you say it's absolutely essential?
I think particularly for conditions where you can't do anything about, it's really important that people have the opportunity to discuss that. So one of the tests that's been around for the longest actually in the NHS is for conditions like Huntington's disease, where at the moment there is no treatment for. And I think that's incredibly important that people have access to really skilled genetic counselling from anyone within the clinical genetics profession, I would say, so that they can really talk about whether they want that test or not. And we know from quite a many years' experience there that many people, when they have that opportunity to discuss it, decide they don't want the test. Yeah. So people say they want it, come forward, talk about it, and then most of them actually fall away. Yeah.
Okay, I suppose to pursue that, because I know, Professor Middleton, in your evidence, you said the situation with regard to genomic counsellors was in dire straits because of the numbers and the retirements that are coming. And clearly we've identified a very real need and an essential part within the NHS and genetic testing for this counselling to exist. But there is going to pressure come from the private companies if they're required to provide counselling. So how do we reconcile this problem of the fact that we're going to hit the NHS that are identifying people that need genetic testing, identifying the support that's needed, because the support's not going to be there physically because of the lack of numbers. So how do we balance this where, NHS should take priority, but then we've got private companies that are making money on the back of it? How do we square the circle?
There's so many ways to think about it, and actually many of the companies do have genetic counsellors on their staff to write their patient material, their customer material, but they're not using them to actually counsel their customers, which they should be. They should be using those skills. And a big concern is this sort of skills drain from the NHS out to industry, particularly when they're being offered 3 times the salary to go and work in industry. And some of the big companies have enormous teams of genetic counsellors. It is something that we're very worried about, and we've been pushing quite consistently over a number of years to increase our training. So NHS England, Health Education England, we've been pushing to increase the numbers of trainees coming through, but also because we have so many really senior genetic counsellors retiring over the next 5 years, we need a recruitment push to bring in more, senior people into the profession. And that needs resourcing, and we've been pushing for that as well. So if there's any outcome from this that can help with that, we'd be very, very grateful.
So should the companies, I mean, we've talked about re-evaluating the data second-hand and then non-medical but medically labelled stuff coming out. Should the companies be responsible for the pickup for the genomic counselling that at the minute is just falling on the NHS once you've got through the barrier of the GP?
Yeah, can I answer that? So, I mean, a few of the companies offer testing for really serious conditions, so young onset Parkinson's, Alzheimer's and breast and ovarian cancer. And if you have those tests, what they offer in terms of counselling is access to a YouTube video that tells you how great it is to be informed of your risk. And no actual direct link to a genetic counsellor who can actually support you. And often people don't know they're going to have an emotional reaction until they have it, because that's the point where they say, oh my goodness, how am I going to tell my parents I might have an increased risk of Alzheimer's? Where's it come from? It must have come from one of them. And then you start to think about, well, what's the actual implication of this? So yes, I would say the commercial companies have a duty of care to their customers to pick up the pieces and not just rely on external, people who aren't even paid by them to pick up the pieces.
Would that extend in a sense that if this is occurring within the NHS, all of these discussions are happening at the same time, whereas if it's a private company, there's bound to be a space between results coming out, emotional hit, emotional questions, let's say in a brilliant case getting support from counselling, but then having to go back within to the NHS, and that time scale exists. Is there any consideration on how that can be shortened, but with the responsibility, so it doesn't become a surprise on resources, if you like, this?
I would agree with what Anna says, but I also think there's scope for the NHS to inhabit that space that's currently inhabited by commercial companies much more. And I think there's moves afoot to do that. So the Advanced Disease Detection Cohort will do that to some extent. And I think that's a good move, because it'll bring those what feel like polar opposites together a bit more than currently, and allow those mechanisms to be thrashed out a bit more. I suppose at the moment I would think that the direct-to-consumer industry is fine for ancestry testing, but is actually not that helpful to the NHS to stray into health predictions by and large. And the more that the NHS can reach out, or the public sector can reach out and include that, the less we'll get these polarisations.
So the actual answer is an expansion within the NHS for those critical and severe potential genetic identifiers, rather than relying on private companies to highlight it.
I think the critical and severe potential identifiers are already well dealt with by the NHS. There might be some questions about whether the screening to get those people in the NHS, picks up absolutely everybody, and I'm sure it doesn't. But it's the commoner diseases where there is a genetic contribution that I think the NHS can do much more. And I would see that much more as a development in public health, I suppose, than in individual predictions.
I think there's a real challenge around that space. I think it's great that we have the Treasury's just invested 70-80 million pounds in this advanced detection of disease cohort. That's a really good thing, because the science is advancing very rapidly, and if people want to know what their risk is of common disease X, there will be commercial companies that will provide that information. And if the NHS isn't sufficiently rapid, there is a risk of reasonably large numbers of people coming and having information that they really feel strongly is relevant to their health, and it's going to degrade the trust in genomic medicine in general, in specific, and more generally in the NHS. So I think there's a real time aspect to this which is quite critical. I think we're quite well placed with the large-scale translational research projects that can gather the evidence that enables us to to implement rapidly, but we're going to need to implement rapidly.
Yes. And one thing I'd just add, if I may, is that we did a small public engagement exercise where we asked people about direct-to-consumer testing, and they fed back very much that they thought that might be the responsible thing for them to do because they knew the NHS was cash-strapped, and they thought actually it was something that they should be doing to save the NHS money, not realising that actually it's often unhelpful.
Thank you. Thank you, Martin. Just before I hand over to Bill, I mean, obviously there is a range of impacts that an individual can feel depending on the outcome of a test, but you don't know the impact until you've had the results of the test. Is it worth considering that before any test there should be some form of counselling, some form of input, warning, come with almost with a health warning, to use the...
I think it depends on what the likely predictive value is. If it's a very low predictive value, then I'm not sure that we would want to recommend counselling. But when it's a very highly predictive test that has big implications either for no treatment or for drastic treatments, then I think we absolutely should be saying that. But they're going to be few and far between. They're rare, those conditions. So it's not as unmanageable as it may sound, I think, to recommend that. The more predictive a test is, the more we need to give people the opportunity to consider that beforehand.
Thank you very much. Bill?
Thanks, yeah. I sense that there's sort of great expectations amongst the public and indeed the medical profession in relation to genomic medicine. But what extent does that promise or anticipation depend on access to genomic data from healthy people, and how else could we gather that efficiently and presumably ethically to allow the system to work? I think a lot of it comes from that data.
I think that's a really great question, because so far much of our knowledge about genomics comes from people who have particular genetic conditions. So we then find the gene responsible and we think that gene relates to that disease. Actually, what we find when we look in healthy populations, that certain gene variants that we thought predicted a disease really well doesn't seem to very much in a healthy population, and it doesn't seem to very much in an older healthy population either. So we need to learn much more about what genetic variation does in a particular context. And I think there was a slightly simplistic view perhaps before of one gene means this disease, and now we're beginning to realise that, well, even if it's a strong gene, we need to know about the context around it, both the genetic context around it and the environmental context around it, before we can do the same thing with a healthy person. So I think it's really important not to conflate a diagnostic genetic test in a person who has a condition with predicting that a healthy person who has that same variant will get the disease in question. The two are often confused. People often think it's the same thing, but it is far from that.
And the more research that we're doing on healthy populations, we're realising that there are people walking around with very serious-looking genes who are not unwell. They're healthy. Yeah. So what is it that's protecting them? Other genes, environment, and so that means it's very hard to predict what it's going to do.
I was just going to say, I agree with everything that's been said. We're actually in a really good position in the UK, partly because of the UK Biobank and the fact that is currently being sequenced so that it's high quality, so you're getting the same kinds of highly predictive variants that we're seeing that you don't get from necessarily an ancestry test. And that the data has started flowing out from that, and we're starting to identify these kind of resilient individuals and start to try and to disentangle the factors that influence why people are not manifesting with the disease that we might expect them to have. So I think we're going to see a big growth in the next 5 years because of things that are already in the pipes. And part of this is actually government investment in things like whole genome sequencing of UK Biobank, which is a good thing.
Yeah.
That's the system that was set up as far back as 2012. Was that 2012 that was set up?
The recruitment set up, I think, 2006 to 2010.
So it's that far back.
But then the sequencing has only really been done. Actually, the sequencing of all the genes in the genome has actually been funded by a pharmaceutical consortium that's then putting the data back into the public domain.
We're now harvesting the good work that was done.
Exactly, and so this year, for example, the first the gene sequences of all the 20,000 genes in the genome were released for researchers for the first 50,000 individuals from UK Biobank, and I think by the end of next year we should have all 500,000. And that's going to be an incredibly useful resource for looking at exactly the thing that you mentioned.
And it's already been useful in highlighting the discrepancy we talked about earlier between SNP array technology and sequencing and the false positive rate, but also in what we call the penetrance of a condition, i.e. the chance that if you have a genetic variant, that it will show itself in the form of a disease. So looking at the healthy population, we find that particular variants have a much lower chance of manifesting in disease than we previously thought. So it's been very useful for those two examples already.
This is maybe along the same line of question. What was your thoughts on the government's plans to gather genomic data from asymptomatic individuals? That is, understand it's individuals that don't present, they don't show symptoms. So you're very supportive of that.
Very supportive, and not just that, but also of individuals from around the world, because don't forget that the way we've migrated might well influence that gene that we think is important. So the genetic background may well influence a particular gene. So we find that certain variants in populations, say from North Africa, behave differently than from Northern European ancestry. So we need to collect more than just Northern European ancestral healthy people. We need to have a much wider.
I would say that the only limitation that I can think of with respect to what the activities that are already going on is to do with the accessibility of the routine clinical data that's available on those individuals that are part. So for example, if you're a member of UK Biobank and you live in Wales, your primary care data will definitely be part of that resource. If you live in England, only 40% of those individuals, their primary care data is part of that data resource. And there are some conditions where the majority of care takes place in primary care, and so you don't, diabetes being one of them. And so the benefits of that cohort are not being maximised because of the lack of availability of primary care data for a large fraction of the cohort.
Yeah, that's a really good point.
Sorry, another point along the same lines is, so for healthy volunteers who, in an altruistic sense, want to contribute their data towards this enormous mapping exercise to try and understand human health, there is an expectation that they might like to have something in return for that data in terms of results of some form. And as we've already said, when you're looking at genetic potential disease in a healthy population, it's actually very, very difficult to predict whether the genes are going to play out and cause disease or not. And, you know, if we're looking at sequencing, you know, tens of thousands, hundreds of thousands of healthy volunteers, we would argue it's perhaps a little bit premature to be choosing at this point what to give back to them in terms of results, never mind who would actually be explaining those results and picking up the pieces.
Yeah, I think the desire to want information from something that you've donated is very understandable, but it's partly a result of the whole discourse about genetics being so clear-cut. And if we could introduce a bit more that it's not quite as clear-cut as that, people might not want that so much.
It's often referred to as the Government Genomic Volunteer Service. So I'm hearing from you that it should be expanded in as broad a base as possible, covering different nations, different cultures.
Absolutely.
How would you achieve?
But we need to think very carefully about what information we give them as a result of that testing. So we might want to recognise their altruism, but we might not want to recognise it and saying, here's your result and your risk, until we've got some very good evidence that that is robust.
So time for a wee supplementary. It's the word that's entered my mind is the word dormant. In as much as the system can detect a risk, but can that same test or system tell you that will be an active risk, or will it remain a dormant risk?
I think
that's not meant to be a wicked question.
No, that's a really good question, because I think the more we look in healthy people, the more we will realise that it's a risk based on previous information, but it's unlikely to ever manifest. But it's very difficult then, because you'll be screening a lot of people because you've identified them at high risk who will never go on to develop the condition in question.
The system can't tell you that?
No, not at the moment, no.
Thank you for that tail end, but that was a good note at the moment.
Thank you. Following up on that, therefore, have advances in machine learning and AI helped to improve that spotting of patterns? And should we broaden the number of people in the system so that you can better predict whether or not genes and how they interact with other genes will manifest itself into disease.
That will be resolved in time, but we need access to enormous data sets from people willing to donate their data. Millions of people need to be willing to donate their data.
And I think there is a real opportunity for the UK here because of the National Health Service. We do have the capability of aggregating data across a large number of people. The US has challenges around its privacy laws. The Scandinavian countries do things very well, but they have smaller populations. It is a real opportunity for us. Yes. But there are barriers to being able to share data across the NHS and aggregate it together. And it's only really that the most benefits will accrue by actually bringing the very large data sets together. I mean, genetics as a whole has used data analytics technologies that are kind of entering into other spaces for many years, indeed decades, and will continue to do so.
I don't need to remind this committee that care.data didn't quite succeed in that aim, but that's really important. We have got a National Health Service, but sometimes it doesn't feel national because individual trusts are worried about sharing data outside their trust. And so, privacy concerns do enter into this, sometimes apparently unnecessarily, but they do need to be taken into consideration. I think there's much greater opportunity for sharing or access to currently available data, as well as expanding it beyond that.
So my main area of work is on rare genetic diseases, developmental disorders of children, and families often really can't understand why we cannot access the data they would really like us to be able to access as researchers. And I think that's one thing that we ought to think a bit more clearly about as a society, is how we enable people to participate in research in the way that they want to participate in research. We can kind of have quite 20th century roots of people participating in research.
Yes. Is it clinical practice or is it research, rather than recognising that they're really sort of entwined?
Thank you very much. Vicky Ford.
Thank you. My questions are about regulation and about the in vitro diagnosis regulation, which I understand is coming into force in 2022, and will bring in place those minimum requirements for clinical validity and counselling. To what extent does that new regulation address the concerns you have about direct consumer testing?
Well, in the regulation, it doesn't actually define clearly what counselling is.
Okay.
And sometimes it's the words counselling is used on its own, and sometimes it's genetic counselling. And so if we think about genetic counselling as a service offered pre and post test for really serious life-threatening inherited conditions, then yes, the regulation will be incredibly helpful, and that would really tighten up what's happening in the commercial sector. But if it's genetic counselling just broadly, anybody can do it because they're assuming it's a conversation about genetics, then it's not going to be terribly helpful, because that's where we are at the minute.
I don't think it's terribly helpful in the movement between different tests, for example, so reanalysing data and that sort of movement. I don't think it will have any teeth on that, as far as I understand.
I don't have anything more to...
So I think, Annika, in your evidence from the Society for Genetic Medicine, you listed 5 areas where you thought regulation could be improved. The greater transparency and sensitivity of tests. And what I want to ask is the others, if they agree that these are the right 5. Okay. The 5 were the greater transparency of the sensitivity and specificity of the test, the greater transparency of the clinical validity and utility, better measures to detect and correct hype and mis-selling, and measures to highlight the possibility of familial inferences, and an obligation to ensure access to clinical services to discuss genetics or offer genetic counselling. Is the panel agreed that those are the 5 areas where regulation needs to focus?
Absolutely, and the key one for me is that partnership between the commercial company, where they give a result that has an emotional fallout and knowing exactly how to pick up the pieces. And expecting the NHS to do that is not appropriate, but there could be more of a partnership where we can work out who will pick up those pieces and how that will be done.
One of the points that we listed there, we haven't really talked about yet, is the familial inferences. Mm-hmm. And of course, when you've got a genetic test that's only very mildly predictive, then that's not relevant. But if you've got a really strongly predictive test result, then you need to think about, and as mentioned, sisters, for example, somebody who's got breast cancer, but we need to think more widely about how we let people know, how we let them know, respecting their possible wishes not to know, how that information might flow in a health service at the moment that's very much individual practitioner, individual patient. So that's an area that I think the direct-to-consumer companies haven't really looked at all.
Yeah.
I think as a general principle, genetics should follow the same kind of rules and modes as other medical tests. I think the areas where it departs, that's where, and I think the ability to, the value of the information for family members is something that's particularly unusual about genetics compared to other tests. So I think the counselling needs to be targeted to the kind of particular issues which, either related to family or to these highly predictive areas. And given the challenges, I think, and the limited resources, we should focus on targeting it where it needs to happen, and maybe lesser work from areas which are more akin to either ancestry or tests that are not so predictive and are more akin to things that you would get from your GP about your cardiovascular risk, for example, from your lipid profile.
So back to the IV diagnostics regulation. Are you saying that's just a good first step and not going far enough, or we shouldn't have done that way altogether?
No, I think it's a great first step, and it needs to go further. Consent is a very big issue in the commercial genetic testing setup. So it basically really doesn't exist. So anybody can send in a saliva sample from as many members of their family as they like, including their children, just spit in a tube and send it off. And the results come back to the person whose account it is with the commercial company. And so there's so much tightening up that's needed about the process, the management of samples, the way results are given, being even sure that it is a human sample that's been submitted. There are cases where someone sent in tap water or a sample from their dog, and a report has come back giving cardiovascular risks. There's quite a lot of quality control issues that need to be tightened up.
And that's covered by the regulation.
It would hopefully be.
I understand that the regulation specifically says that counselling is needed when tests relate to predisposition for currently untreatable conditions. What about when it relates to a predisposition for a condition which is treatable? So the other side of that.
I think that's quite an unhelpful distinction, because there are very many very strongly inherited conditions, and I'm just thinking of some of the young onset bowel cancers, where you can have children with bowel cancer. And it's treatable in that you could offer colonoscopy screening and remove sections of bowels and potentially save children's lives, and that's treatable. So having a test early to pick up a predisposition to bowel cancer, having screening, can end up being treatable for the condition. So, but the whole process of having that testing requires an awful lot of thought and consideration of the family dynamics, the moment that you need to test, loads of counselling that can go with that. So I actually find it a little unhelpful that distinction's been made between treatable and untreatable. And also, this is a moving target. What's not treatable a few years ago is now changing.
And defining what a treatment is as well is quite a difficult one. Yeah,
it's sustained.
Good point. Do you think that 2022 is too far in the future for that to come into force? Should we be implementing it sooner?
It's really interesting. Certainly in my field, it feels like it's not even on the radar at all. Genetic counsellors in the UK have not heard of this regulation. They're not concerned about it. They're not thinking of implementing it. The communication about this has been way off the sphere for the clinical genetics community. I don't know.
Yeah. I think that's right. And also I think that when it has been communicated, it feels like it won't do everything. It will be very good at dealing with the technical aspects, perhaps, but not the bits around it. So I mean, great if it does, but I feel that it would be good at regulating some aspects of direct-to-consumer tests, but that doesn't tell you, doesn't do anything about the misunderstandings that people come in to those tests with, and therefore the how they carry those misunderstandings
So
on.
given that the UK is committed that it will implement this regulation in 2 and a bit years' time, are you suggesting that this interim period should be used to look at how we use that to more broaden its scope?
Absolutely,
and clarify its scope.
And pad out exactly what it means in terms of the delivery of care.
Do you agree?
Yes.
Yeah, I think I'm not sure if this is so germane, but I think it's worth thinking more generally about genomic medicine and what legislation ought to be in place to get to where we want to get to. I think the regulation of commercial testing is one particular area. I think there are other kind of areas where maybe some help in thinking of it in the round in this period. So one particular area is around the use of insurance companies' use of genetic information.
Yes.
If we talk to people about genetic information, if we want to have large numbers of people signing up, for example, the advanced detection of disease cohort, that's 5 million people, that's 10% of the population, is our insurers going to be able to access those data and what for? The US has had a Genetic Non-Discrimination Act for 11 years now, clearly hasn't harmed there. Why don't we have something like that? The second thing that they often have big concerns around is the potential for forensic use of that genetic information. And I think having clarity from government about what the Home Office can and can't do would again help to build trust with the large numbers of people we're anticipating participating in these large-scale research projects to enable us to get to where we want to get to. So I would see this as the in vitro diagnostics as a piece of the puzzle, but not the whole. And I think it may help for this committee to think about the whole.
Yes, I think if I could just expand on that a bit, I think that if we say that we're going to regulate something without also telling people why and in a way that they can understand, they're just going to find another way around it. So people will feel that they can't access something that is rightfully theirs or that they could have bought before. If they don't understand what the limitations of it are, then they'll buy an online kit from the States or somewhere else. So I think what you said earlier about expanding the work around so that people understand what a test might show them and more importantly what it might not show them is a really important piece of work to go alongside that, so that it doesn't feel like you're not allowed to have this thing that you feel you might have a right of access to.
That's a really important point. It's got to be done with patient organisations.
Yes, yeah. And public discussions about genetics in the media. Every article about genetics is accompanied by a nice, glossy, clear, technical picture. So, it's no wonder that people think it's nice and clear-cut and straightforward.
But it's not just when you're expecting 10% of the population to participate in a genetic study. We've got to talk to everyone.
Yeah.
Thank you.
So further to that, and taking all your comments that you've made today as a whole, what advice would you give to a member of the public considering purchasing a commercial genomic test? What would be your key statement to them?
I would ask why. What do you want to get from it? And I'd gear the conversation from there, but I would say that I think it might be an interesting sport to find out how your ancestors have migrated across the globe, but at the moment don't use it for anything else, with the exceptions perhaps of what Matt's identified, that where the NHS really doesn't provide something, so preconceptually and during pregnancy there might be opportunities that aren't available through the public sector at the moment.
I should come back also on the one area that I forgot to mention when you asked the question about what does the NHS not. Pharmacogenetics is actually a key area. That's robust science for many years. Very few healthcare systems have worked out how to do it.
Yeah. It's starting then.
It's starting, but it is challenging, and I think it would be quite reasonable for a member of the public to go and want to know, are they likely to have a very severe response to drug X or not? Because those kind of traits of having severe response are common. Many people in this room will respond unusually to standard drugs at standard doses. And I think that's one particular area that we need to keep a really close eye on, because the gap is not science, the gap is implementation.
Yeah.
And my advice to a member of the public wanting to buy one of these commercial tests is read the small print, because in the small print it will often clearly say we sell your data to other companies, and that's not immediately obvious in the marketing, and that's often the business model for these companies.
And more is not always better. So there is a tendency for companies to offer more and more either pharmacogenetic tests or disease risk tests, and there's a sense that as the consumer that the one that offers the most might be the best, but actually the predictive value goes down so much, and it might be a pharmacogenetic test about a drug that you're really unlikely ever to need, and those sort of issues need clarification much more.
Excellent. Thank you very much indeed for your evidence this morning. It will help us develop our inquiry, so I'm very grateful. Order.